Good evening, students, and welcome to this second session of the NEET PG 2026 final sprint on medicine classes. So, yesterday we started with the cardiology discussion. So, in today's session, we'll be discussing on neurology and briefly about toxicology. So, we do have a lot of high yield areas in neurology where frequently the questions are asked. The common ones being imaging. You do get a lot of images on the CT or MRI where there are certain differential diagnoses given and then they ask. The important points are about differences between upper motor neuron, lower motor neuron. The stroke localization is important, the spinal cord diseases. And since we have had a lot of video-based questions that have been asked, neurology is one place where they do ask you a lot of videos where signs, clinical signs are demonstrated, and you will be asked to identify. So from the neurology, you can get a lot of video-based questions also. Important topics: stroke, neuropathy, GB syndrome, myasthenia gravis, as well as headaches, as well as meningitis and anti-epileptic. So these are the important core areas that we are going to discuss. Some of the important things that you have to understand before we go on to the individual topics is what is upper motor and what is lower motor. Very frequent questions asked. So if you start the nervous system right from the cortex, the cortex, the subcortex, the brainstem, the cerebellum, and spinal cord, that is up to the anterior horn cell. If you look at anterior horn cell, if you're looking at, you will be considering it as the upper motor neuron. From below that, that is the anterior horn cell, the plexus, the roots, the peripheral nerve, the neuromuscular junction, and muscle. These form the lower motor neuron. So this is the basic differences you should know when you consider a upper motor neuron disease and a lower motor neuron disease. So these are the structures which come under each of these categories. Now, the very, very simple differences between UMN and LMN, all of you should know it. The tone is increased, what we call it as spasticity in upper motor neuron disease, which is velocity dependent, anti-gravity muscles are affected, whereas it is decreased in lower motor neuron lesion. That's very important. The deep tendon reflexes are exaggerated. You might get clonus also in upper motor neuron lesion, whereas lower motor neuron lesion, the deep tendon reflexes are absent. Very important is the Babinski reflex. That is, the plantar reflex becomes extensor in UMN, whereas in LMN usually does not happen. Now, the features which are specific for an LMN disease is marked wasting and fasciculations. Fasciculations, that's something we should always remember, is an LMN finding where you have, worm-like movement that happens within the muscle that is seen. Clonus, which is an exaggerated reflex, is always the feature of UMN disease, not in LMN. Now, you should always remember UMN disease can present with LMN findings, especially in the early stages. In a stage of neuronal shock, which may be for a few days, you may find LMN signs, but eventually the UMN signs will appear. Also, the decreased tone, the decreased tone that we say, the flaccidity, can be seen in cerebellar disease, can be occurring with chorea, can be occurring with neuromuscular paralysis or deep sleep, all those other conditions where you can get hypotonia also. But LMN diseases always have hypotonia. The other type of increased tone, what we call it as rigidity. Now, rigidity is classically seen with Parkinson's disease. So Parkinson's disease or extrapyramidal system involvement, you have rigidity where both the gravity and anti-gravity muscles are equally involved, and that is velocity independent. So these basic differences we have to understand because you do get a lot of MCQs based on that. So based on these findings, you can say whether it is a UMN or an LMN, and then you can localize the site of lesion. Let's go on to the overview of the various sites of lesions. So if you look at the cortical lesions, so always it's a UMN disease that is there. The common disease that gets involved in the cortical lesions, for example, the stroke is there. Certain specific features that would be there always in a cortical lesion is if a dominant cortex is involved, you may have aphasia, you can have apraxias, as well as seizures on history. That will always be a feature of cortical involvement that you see. The second localization in stroke commonly you have is the internal capsule, the very important feature, dense hemiplegia. Please remember, the dense hemiplegia, where upper limb and lower limb is equally involved, is the characteristic feature of internal capsule lesion. You will have facial nerve involvement also, and common lesion is a stroke there. This is a UMN, so the reflexes are exaggerated. Next location is the brainstem. Now, brainstem, you have to remember there is crossed. That is one side weakness, other side cranial nerve involvement. Always is a classical brainstem. We will discuss some of the syndromes little later. Coming on to the spinal cord disease. If you look at the spinal cord disease, the important features they would get, again, it's the UMN. The most important feature is the sensory level, bladder involvement, and you will generally have either a paraplegia or a quadriplegia that you would get in case of a spinal cord disease. They may have pain that could be seen, vertebral pain, radicular pain, funicular pain, etc. It could be compressive myelopathy or non-compressive myelopathy. Either of that can be there. The next localization is the element localization we would start with, the anterior horn cell disease. Classical disease that you have is the motor neuron disease or the amyotrophic lateral sclerosis. Here, you have florid element signs. You have wasting, fasciculations that can happen, and it is usually asymmetrical. The next site from the anterior horn cell, the nerve root comes. Again, very important feature, radicular pain, asymmetrical lesions. It will have element features, hypotonia, decreased reflexes. The next, by far the most common element disease that we encounter is a neuropathy, peripheral neuropathy, always distal. You can have a sensory motor with or without autonomic, glove and stocking pattern, diabetes being a common cause that you could see there. The next element localization is the neuromuscular junction. The most important feature is fatigable weakness. So in a history, if they say about fatigable weakness that they are saying, you're dealing with neuromuscular junction disease, myasthenia gravis, and diurnal variation, reflexes are normal, extraocular muscles are involved. Last localization is a muscle. Whenever you have a muscle disease, it's a pure motor disease, proximal predominant, reflexes are usually preserved. You could have a myopathy, you could have a myositis or a muscular dystrophy. So this is how, based on the clinical scenario, you can localize what sort of disease we are looking at. Is it a myopathy? Is it a spinal cord disease? And then we can give an example, what is the type of disease they have. We'll be discussing a few of these in the future slides. Now, certain scales you have to know. The important scales which are asked often are, one is the NIHS scoring system, that is the National Institute of Health stroke scale. This is how you grade the severity of stroke at presentation. There are 11 points here, out of which there is various scoring. So one stands for level of consciousness, where you can grade from 0 to 2, 0 to 3. Second is the best gaze. Third is the visual fields. Fourth is the visual facial palsy. Fifth is the motor, the right arm, right leg, left leg. That's the fifth and sixth. Seventh is whether there is an ataxia. Eighth is whether is sensory. 10th is dysarthria. And 11th is neglect or extinction. So you grade it as 0 to 2 in most of that. And based on that, you get a scoring system. So it is very important for us to understand these headings because this is a universally used. So if the score is 0, we call it as no stroke. 1 to 4 is minor stroke. 5 to 15 is moderate stroke. 16 to 23 is moderately severe. And 21 to 42 is a severe stroke. That's important because our thrombolysis that we do would be for a minor to moderate stroke. You don't do thrombolysis for a bigger stroke because the chance of recovery as well as complications of hemorrhagic transformation is higher. So you would give thrombolysis, tenecteplase as a drug of choice. Very, very important. Whenever we do thrombolysis, our primary intention here is to salvage the ischemic penumbra. So we control the blood pressure and then we give IV tenecteplase. If you have a larger stroke, bigger stroke like 16 to 20, etc., you can go for thrombectomy. That's a procedure that could be better. And this has to be done in centers where these facilities, intervention is available, and you would want to do it early. So stroke grading by NIHS is a very, very important thing that we have to always look for. And NIHS is a universal grading system. 11 points you have to remember. The next important scoring system, which is often asked, is the Glasgow Coma Scale. where you have EVM, that is eye opening, verbal response, and motor response. The scoring is 4, 5, and 6. So eye opening spontaneously is 4, verbal response maximum is 5, where it's completely oriented, and motor response completely is 6. So you can have a maximum of 15 score. So 13 to 15, it's a mild brain injury. 9 to 12 is moderate. Less than 8 is severe, or the patient is in coma. You would have to intubate them. This is used for prognostication as well as assessing the severity of the disease, and also to monitor the patient, whether it's improving or not. Something that has been added to this is the Glasgow Coma Scale with pupillary response that has been added, whether the pupils are reacting, dilated, sluggishly reacting, etc. That's an add-on point. GCS can be used for all altered sensoriums, be it traumatic, be it metabolic encephalopathies, be it stroke. You can use GCS for all these scales. So this is a very important. They will give you certain points. You know, the patient is opening eyes to only pain. The patient is making incomprehensible sounds, and he has an abnormal flexion. So, you know, the score is 2 plus 2 plus 3. So you have the score of 7. So that means this patient has a severe brain injury. So these patients would not do well, and these patients would be anything less than 8 requires intubation for airway protection and sometimes ventilation also. The other important thing that commonly asked is the CSF findings. You get a lot of questions on MCQs with the CSF reports, and what are the features that you would see in that. So remember the opening pressure. The opening pressures are usually elevated in all the meningitis. And remember the normal, 0 to 5 lymphocytes is normal. The protein is around 20 to 40. That's a normal protein. And glucose, there's no fixed value. It is 2/3 of the plasma glucose. So you should always remember that. Now, in acute bacterial meningitis, pyogenic meningitis, it's a neutrophils. That's very important. Proteins is increased and glucose is decreased. Tuberculous meningitis is a chronic meningitis, and the most often feature you see is a lymphocyte. Protein is elevated, sugars is low, and you can get something called as a cobweb formation. So cobweb formation can be seen, and you can do the gene expert or the ADA can be done, and based on that. Bacterial meningitis, you do a gram stain and culture sensitivity. Based on that, you can treat the patient. Viral meningitis, otherwise called as an aseptic meningitis, by far the commonest. Again, here it resembles tuberculous meningitis because the lymphocytic predominant, mild protein elevated, but very, very important is this difference. The glucose is normal. In viral meningitis, glucose is normal. Fungal meningitis, exactly like tuberculous meningitis. You can have cryptococcus, that's common. It could be other funguses also. Difficult to differentiate just by that. For the cryptococcus, you can do the India ink stain, or the cryptococcal antigen can be done. Partially treated bacterial meningitis would resemble any chronic meningitis. So you can have mixed cellularity with elevated protein and decreased sugar. Neurocysticercosis, you might find eosinophils, not very characteristic. Sugars are normal. GB syndrome, this is one non-meningitis indication where we do a CSF, and the classical finding that you get is normal cells, elevated protein. What we call it as an albuminocytological dissociation. Very, very characteristic of GB syndrome. 5th day onwards, you can do the CSF and you will get these findings. Multiple sclerosis, a demyelinating. So you will have mild lymphocytosis with protein elevated. Sugar will be normal. Subarachnoid hemorrhage, you will find a lot of RBCs, and if you keep it for standing, you get yellow supernatant. That is what we call it as xanthochromia, very characteristic of subarachnoid hemorrhage, where the patient comes with headache, can have neck stiffness. Sometimes you might mimic it as meningitis, but we call it as meningismus. So CSF findings, please remember, very, very common question asked, you will have to decipher. Certain specific things that you can do for the CSF, gram stain, you can do for the bacterial meningitis, you can do the culture sensitivity also. AFB stain and gene expert CBNAT for TB meningitis. India ink and cryptococcal antigen for your cryptococcal meningitis. Herpes simplex, especially encephalitis, you can do the PCR. For multiple sclerosis, we do the oligoclonal bands. For tuberculosis, you can do the CSF ADA also. Creutzfeldt-Jakob disease is a slow viral disease, causes early onset dementia and severe cognitive dysfunction. You do something called as a 14-3 protein. That is what we assess from that. And sometimes you can have lymphomatosis or leukemia producing meningitis, what we call it as leptomeningeal metastasis. In that, we do a cytology and identify the cells, and you can do the flow cytometry also from that. So these are specific tests that we can do from the CSF. Let's go on to certain images, some common MRIs you can see here. So you can see the MRI here, non-contrast MRI. You find that there is the temporal lobes. Very classical hyperintensity is seen in temporal lobe. So predilection for temporal lobe, classical herpes. So this is the herpes encephalitis, which has a predilection for temporal lobe. So fever, altered sensorium, they can have seizures. And when we do an MRI, you will find it. Do the CSF, send the viral markers. Treatment is acyclovir. Without steroids, acyclovir is the main treatment. Parenteral acyclovir. Temporal lobe enhancement, classical of this. Here we have again a patient with encephalitis. You can see a CT here, image being given here. And what you're seeing is the enhancement of the basal ganglia. Classical hyperintensities of the basal ganglia. Very characteristic feature of Japanese encephalitis. Very, very characteristic image. Japanese encephalitis. Again, it's an arboviral disease that you have to know about. Now here you find MRI image, and you would find multiple, lesions which you're seeing here. Multiple small ring enhancing lesions, and they could resemble you can see here the basal part. There is a little of exudate that is formed in the basal part, the basal cisterns you can see there, where the cranial nerves are exuding, and you have multiple ring enhancing lesion. This basal exudates, if they give you in history, basal exudates, cranial nerve involvement, all are classical of TB meningitis. It's a chronic meningitis, lymphocytic, fibrin-rich source, so you get a lot of exudates, and that can cause obstructive hydrocephalus also. Now, this is a very characteristic appearance of what we call it as the neurocysticercosis. You can see the starry sky appearance, various stages. So you can see the scoliosis here in the first film. You can see scoliosis. You have big ring enhancing lesions, and then this is calcification beginning, eccentric scolex, and this is the last stage where you have multiple calcified lesions itself. So these are the various stages of neurocysticercosis. So you should know the life cycle. Praziquantel albendazole with ivermectin is the treatment of choice. Antiepileptics may be needed, and you can do the antigen from the CSF can be done for diagnosis. This is one more classical image, very classically you can see here multiple round lesions, and there is an enhancement. So what we call it as ring enhancing lesions. So very common question asked, what are the differential diagnoses for ring enhancing lesions? So it could be tuberculoma, it could be toxoplasma, it could be cryptococoma, it could be neurocysticercosis, it could be abscess, it could be gliomas that could be there. Rarely it could be due to lymphomas. So it could be infection, it could be malignancies, it could be abscess that you could see there. So wide variety of differential diagnosis is there. Usually an HIV patient, ring enhancing lesion, if they are more located in the basal part, then it is tuberculosis, large size, more edema, toxoplasmosis, more close to the white matter, toxoplasmosis. So you will have to evaluate these patients. So differential diagnosis for ring enhancing lesion, you have to importantly remember. So this is a sagittal section of the MRI where you're seeing a lot of white matter changes. You can see these. These are what we call it as the plaques. And you can see there are certain finger-like projections. Classically, what we call it as Dawson's fingers. Very characteristic of multiple sclerosis. This is a very common image. So white matter changes that you're seeing, and these lesions are what we call it as plaques. So here you have a sagittal section of the cervical cord, and you're finding a hyperintensity, a rounded hyperintensity located in center of the spinal cord. This is the classical syringomyelia. So syringomyelia is a central cord lesion where there are cavities that are formed in the center of the spinal cord. It starts compressing eccentrically. These patients have very characteristic features. They have dissociative sensory loss, descending weakness, cape-like distribution of sensory loss, shawl sensory loss could be there, and they have florid element signs in the local area. Supposedly this is C3, C4. You'll find wasting in that site, and below that it is UMS. So it's one of the differential diagnosis for an intramedullary myelopathy that you see. So here you find MRI image. You can see the T2, T1 and flare. So you find that the ventricles are dilated, huge ventricular dilatation you see, and the ratio of the ventricle to the cortex. And you find a lot of atrophy here of the brain that you're seeing here, atrophy of the brain. So this is benign intracranial hypertension or dilated ventricles. It could be a normal pressure hydrocephalus or an obstructive hydrocephalus. History is very important. So dilated ventricle with the opening pressure being normal, we call it as normal pressure hydrocephalus. Benign intracranial hypertension, or otherwise called a pseudotumor cerebri, you might find edema, mild ventricles enlarged, and the pressure will be very high, seen in younger patients. NPH is older patients where they are wet, that is, they have urinary incontinence, they are wobbly because of ataxia, and they are wacky because of dementia. So dilated ventricles, you might be in obstructive, non-obstructive hydrocephalus. So based on the history, you will have to localize the diagnosis. Very characteristic appearance that you're seeing on a sagittal section. You can see what we call it as the hummingbird sign. So hummingbird sign, you can see the midbrain here. This is the hummingbird sign, classical of a disease called as progressive supranuclear palsy, or what was earlier called as Steele-Richardson-Olszewski syndrome. Patient has gaze palsies, they have recurrent falls that they see, and one of the Parkinson's plus. So this is a very characteristic image that you can get. This is one more MRI image, the classical appearance, what is called as a hot cross bun appearance. This is a characteristic Parkinson's plus called as a multisystem atrophy that you're seeing here. Very characteristic finding that you're seeing the hot cross bun sign. This is the panda sign, the face of the giant panda they call. So this is classical of Wilson's disease. Maybe seen in other deposition diseases also. You can see here the face of the giant panda. It's a very characteristic feature that you would get. Now this is a plain CT, the CT venogram. We can see this. You can see this delta. What we call it as an empty delta sign, and you can see the sinuses. The venous sinuses are totally clogged. This is the classical feature of cortical venous thrombosis. Very important sign, the empty delta sign. And this is the thrombosis. So patients can come with headache, they can come with seizures and altered sensorium. And you do this imaging. So these patients have to be immediately started on anticoagulant as good prognosis if you treat it early. The other feature that you can see, this is a angiogram scene. You can see the aneurysms. Very common question, the aneurysms, the localization of that. Most commonly located in the ACOM, followed by the MC, followed by the PCOM, as well as the basilar tip aneurysm. So circle of Willis, and you can see the aneurysm that is there. This is the aneurysms that are commonly seen. Produce subarachnoid hemorrhage, and if the size of the aneurysm is big, they require coiling or ligation. Presently, we do coiling. Some very important, both in neurosurgery as well as in medicine, they can ask you, this is a plain CT. So how do you differentiate an extradural hematoma versus a subdural hematoma? Biconvex, like a lemon, is extradural hematoma, and concavo-convex, like a banana, is subdural hematoma. So they can give, this is in one image only we have given, you can have it in two different images, and they can ask you to identify causes, and they require surgical intervention. Certain images, so you can see here, you can see that there is some sort of a mask-like facies. You're seeing a frontal balding. There is ptosis that you're seeing here. And this is a very, very Cashian. The facial muscles are involved. This is the classical facioscapulohumeral dystrophy. The face, what we call it as a hatchet face, the patient is having one of the inherited muscular diseases. You see here, very classical sign getting demonstrated. This is what we call it as the glabellar tap, and the persistent blinking, very, very characteristic sign of Parkinson's disease. Persistent glabellar tap is otherwise called as Meyerson's reflex, very characteristic of Parkinson's disease that you're seeing. So this is a very common video that they can keep you, and they can ask you what is the finding that you're getting. Here you can see the patient. So she's attempting to close the eyes, but the right eye is not closing, and you're able to see the lower palpebral conjunctiva. You're seeing bulbar conjunctiva is visible. So this is called as the Bell's phenomena. Bell's phenomena is characteristic of the lower motor neuron seventh nerve palsy. So classical element could be Bell's palsy, could be in Ramsay-Hunt syndrome, could be due to middle ear infections, could be due to parotid tumors, could be due to brainstem strokes. So this is an element, very characteristic Bell's phenomena that you see. One of the common things that can kept as a video. So again, the patient, you can see there, weakness of the face. She's not able to blow on that side. So right side, she's not able to blow, and the eyes are weak. So this is classical element facial palsy that you're seeing. One of the other things they can ask you about element facial palsy is a Ramsay-Hunt syndrome. So where there is facial nerve palsy and vesicles, you can see herpes zoster in the fifth nerve territory, and geniculate ganglia is involved. So here we have an involuntary movement. You can see there the patient has a little bit of hyperkinetic movement disorder. So she's trying to resist it. She's trying to do some movements, one side, both upper limb and lower limb. It's not very rapid. It is a little slower movement, called as a writhing movement. So this is the classical ethetosis. This is how ethetosis will look like. So one of the hyperkinetic movement disorders that you could see there. So it could be congenital conditions, it could be acquired conditions that could get it. So here you can see the head nodding, classical head nodding that you're seeing here. The patient is continuously head nodding. So this could be part of a cerebellar disease, what we call it as titubation. Or similar tremors can be seen with essential tremors also. So you can see here the patient is looking up and you're seeing a upbeat nystagmus, very, very characteristic upbeat nystagmus. And then you can look at the patient has nystagmus, very classical upbeat nystagmus that you're seeing there. It's going up. So this type of upbeat nystagmus is very localizing to a brainstem lesion, especially the midbrain lesions. You can get it. He has a lateral gaze nystagmus also, but the upbeat nystagmus is very classical. So you can see that the downbeat nystagmus, very important. The downbeat nystagmus localizes to lesions at the foramen magnum. So they can show this and they can ask you what sort of diseases you can get it. Common diseases where you can get nystagmus is cerebellar diseases, where you have horizontal gaze nystagmus and rotational nystagmus that you get. So here is a very important clinical sign that you can see, what we call it as the flapping tremor, or it's otherwise called as asterixis. So you can see that commonly seen with hepatic encephalopathy, can be seen with uremic encephalopathy, can also be seen with carbon dioxide narcosis. Sometimes you can get drugs also. So this is a negative myoclonus, very characteristically seen with hepatic or carbon dioxide narcosis. So you can see here, the tongue is deviated to the left and there is wasting and fasciculations, fasciculations of the tongue, very characteristic. So this is an LMN sort of 12th nerve involvement, wasting and fasciculations you're seeing. And one disease we should remember is the bulbar variety of motor neuron disease, where you can get this very, very characteristic feature of fasciculation. So this is the fasciculation that you're seeing. MND is one of the important diseases. You can get fasciculations in organophosphorus poisoning. You can get it with atropine. You can get it in hyperthyroidism, post-polio progressive muscular atrophy. But please remember, MND is the most common disease that you get. So here the reflex is getting elicited, and you can see here ankle jerk is getting elicited, and you're finding clonus. So they can ask you, persistent. This one. So this is clonus. It's a UMN disease that you're seeing. So this is clonus that you're seeing. The root value S1, S2 of the ankle jerk. Again, the root value of the reflexes, you should remember they can ask you for the MCQs. So here you can see a very characteristic, what we call it as the pill rolling tremors. Resting tremors, pill rolling tremors, classically seen with Parkinson's disease. You can see that the classical pill rolling tremors, resting tremors that you see. Here you have an image where you're seeing the greater auricular nerve, greater auricular nerve is enlarged. So nerve thickening, you can have the ulnar nerve, common peroneal nerves, etc. Getting involved. Nerve thickening, very importantly, seen with leprosy, can be seen with CIDP, that is chronic inflammatory demyelinating polyneuropathy, can be seen with hereditary neuropathies like the Charcot-Marie-Tooth disease, Dejerin-Sota's disease, and you can get it in case of neurofibromatosis also. So nerve thickening is an important feature. This is the greater auricular nerve that has been very much prominent. You can see this is the greater auricular nerve. So some of the gaits, so again, videos can be shown. So you can see here, the patient is lifting his leg and putting it up. So there is a foot drop. So this is what we call it as the high stepping gait. There is a lift of the leg. There is an element weakness. So you can see the wasting also. High stepping gait, common peroneal nerve injury can be there. Sometimes in radicular involvement also you can get. So this is a foot drop that you get, bilateral. So here you have a patient who's having, unsteadiness, broad-based, and she's going to wobble on both sides. She's falling to one side, wide-based gait, unsteady gait, wide-based gait. Very, very characteristic. Ataxic gait. Ataxic gait. Very important cause is cerebellar ataxia. Even sensory ataxia, you can get it, but they will be, with open eyes, they'll be able to walk. Only when they close their eyes, they'll have this issue. So you can see here the patient is having an involuntary, rhythmic movement disorder. You can see there hyperkinetic movement disorder. She's doing it very rapid, distal onset that's there. And she's trying to mask it. And also she can have some lip smacking movement. She's unable to keep the eyes closed. She's doing some lip smacking. The tongue keeps going inside and coming out. So you ask her to keep the tongue, but this is what we call it as a jack in the box phenomenon. Classical feature of chorea. What we call it, these are all features of motor impersistence. You ask her to do something, she will not be able to sustain that. So this is what we call it as motor impersistence seen in chorea. Chorea, the site of lesion is the caudate nucleus. Common causes could be Sydenham's chorea, could be rheumatic chorea, chorea gravidorum, sometimes toxin-induced, sometimes hyperglycemia can also produce this. So here you're seeing classically, short, shuffling, stooped posture, gait that the patient is having. And, is slow, the classical festinating gait of Parkinson's disease. This is a very characteristic gait. Stoop forward, slow, shuffling, short steps the patient is taking. So here you're looking at a demonstration that's been happening here. You can see that this phenomena is rigidity superimposed with tremors, what we call it as the cogwheel rigidity. So this is the cogwheel rigidity, very characteristic feature of Parkinson's disease. You get this cogwheel rigidity. And here, again, the Parkinson's patient, you can see the slowness, the slowness of movement the patient is having. There's so much difficulty with getting the. So this could be part of Parkinson's, it could be part of akathisia, it could be part of apraxia. So here you can see that the patient, you're keeping a mark at the umbilicus and asking the patient to raise his neck. You can see that the umbilicus moves upwards. So this is a classical sign called as the beaver sign. So that means upper abdominal muscles are normal, lower abdominal muscles are weak. So the umbilicus moves up. So it localizes the lesion to T10. So spinal cord disease at T10 produces this classical beaver sign. So this is something that you have to remember. You can also get beaver sign in facioscapulohumeral dystrophy. So again, you can see here one reflex being elicited. So this is the jaw jerk. And you can see normally jaw jerk is absent. Here the jaw jerk is present. What we call it as exaggerated jaw jerk. This is a classical feature you get in case of pseudobulbar palsy. So pseudobulbar palsy, you get exaggerated jaw jerk. It's a bilateral human above the level of midbrain. So here again, involuntary movement you can see there. The patient is asked to hold his hands like this. This is what we call it as the wing beating tremors. So wing beating tremors, very, very characteristic of Wilson's disease. Wilson's disease. This is a patient. So you can see there when they put air, he's having hydrophobia. Hydrophobia, very, very characteristic feature of rabies. So this is an encephalitis where they have hydrophobia and aerophobia, very characteristic of rabies that you'd get. Here, the ankle jerk is getting demonstrated. You can see the reflex. You have a good contraction, but the relaxation is delayed. So this is what we call it as the hang up reflex, hang up ankle jerk, otherwise called as the Voltman sign, characteristically seen with severe hypothyroidism. Severe hypothyroidism, you get this reflex. So here again, you have seeing a video and you can see there in the muscles, spontaneous muscle, fasciculations. There is wasting and you can see fasciculations all over. You can see there the spontaneous fasciculations that you're seeing. This is a very, very classical disease of motor neuron disease. So MND, you get fasciculations. Whenever they give a video of fasciculations, remember the diagnosis is MND. So you can see here a video. The patient is asked to protrude the tongue out. You can see the uvula is deviated. The uvula is deviated to the right side. So right-sided, there is a deviation. So this is a bulbar palsy. The 9th and 10th cranial nerve is involved. So you have a deviation of the angle of the mouth. So these patients will have nasal twang speech. They'll have problem in swallowing. They can be prone to develop aspiration pneumonia. So this can be in a brainstem stroke, or it could be due to a bulbar muscles getting weak, which could be due to neuropathy, GB syndrome, diphtheria, or even myasthenia. So here again, you can see the spontaneous nystagmus, bilateral nystagmus, very, very characteristic of cerebellar disease. So bilateral spontaneous nystagmus, very, very characteristic of cerebellar disease. You can see here the plantar reflex being elicited. So it's a very common thing they ask you. The plantar reflex, the root value is L5 S1. And you see there is normally you should get a flexion. You're getting dorsiflexion of the great toe that you're seeing here, fanning of the other toes, the other reflexes also. The ankle is getting flexed, the knee is also getting flexed. These are the other ways of eliciting the plantar. The open hams, the Chaddocks, the Schaffers, these are alternative ways of eliciting the plantar reflex. So this is an extensor plantar or Babinski sign, which is characteristically seen in upper motor neuron. So these are the videos that we have discussed. The next category of questions that we are going to look at are the common drugs that are going to be asked. So epilepsy, very, very important. Seizure disorders. Common drugs, you have the sodium channel blockers, phenytoin, fosphenytoin. The important side effects of phenytoin, you should remember, gum hyperplasia, hirsutism, ataxia, osteomalacia, megaloblastic anemia, drug-induced lymph nodes. You can get something called as a pseudolymphoma also. Fosphenytoin is a parenteral preparation, IV alternative to phenytoin. It has a few infusion reaction. We can give it faster. Carbamazepine, very important. Other than seizures, it's used for trigeminal neuralgia. Important side effects, Stevens-Johnson syndrome, agranulocytosis, and SIA. Very important, please remember SIADH. Oxcarbazepine, drug of choice for focal seizures. Hyponatremia, that's SIADH is common. Lamotrigine, a newer drug, can be used for most of the things, but again, SGS, that Stevens-Johnson syndrome is caused. Lacosamide, focal seizures. Important is the first-degree heart block that you can get it. Rufinamide is a drug of choice for Lennox-Gastaut syndrome. It shortens the QT interval. So that's one side effect that you have to remember. The calcium channel blockers, ethosuximide, common drug for absence seizures, usually well tolerated, not much of side. The delta to delta calcium channels, that is the gabapentin, pregabalin, and zonisamide coming there. So gabapentin and pregabalin are used for neuropathic pain also. Important side effect is sedation and weight gain that you have. GABA enhances the benzodiazepines, drug of choice for status epilepticus. If you give parenterally a higher dose, respiratory depression can happen. Clonazepam, drug of choice for myoclonic seizures. Sedation is a side effect. Phenobarbital, important side effects is the enzyme induction, used for status only. Valproate has a wonderful effect for a variety of epilepsies, can be used for migraine also. Important side effects is teratogenicity, pancreatitis, and hepatotoxicity. Tigabayne, it's a newer drug which has come for absence seizures. Vigabatrin for infantile spasms. The newer drug, that is the levetiracetam and the brivacetitam, it's a very broad spectrum anti-epileptic drug which acts on the SV2A ligands, and irritability and mood changes are the side effects that you have. The newer drug, the glutamine receptor antagonist, that is the perampanel and the felbamate, produces dizziness, hepatotoxicity, etc. Topiramate is one drug which is used for migraine as well as for seizures. Multiple actions. Important side effect is renal stones and weight loss. So topiramate is good for weight loss. Now the seizure types and the drug of choice, again a common question. Focal seizures, the best drug is carbamazepine, followed by lamotrigine or levetiracetam. Levetiracetam can be used for many, but carbamazepine is the best drug. The alternatives are oxcarbazepine and lacosamide. GTCS, valproate is the best drug, followed by levetiracetam. Alternatively, you can use lamotrigine and topiramate. Absence seizures, drug of choice is ethosuximide. Myoclonic, valproate, you can use clonazepam also. Atonic seizures, valproate is a drug of choice. Status epilepticus, a very common question asked. The first drug is benzodiazepines, lorazepam or diazepam, followed by phenytoin and fosphenytoin. If not recurring, you can give levetiracetam. If not, phenobarbital. Then you may have to put the patient on muscle paralysis and ventilation. Some of the EEG waves, they can show you the images that can be seen. So various waves are there. So if you look at the various waves, the delta wave is the slowest of them, which is seen in deep sleep that you see. So 1 to 3 hertz, followed by the theta wave that is there. Deep relaxation, meditation time, you can get the theta waves. Alpha wave is the common relaxed calm, 9 to 14 hertz. Awake waves are the beta waves that you see, 15 to 30 hertz. And in gamma waves is where you have problems. So seizures, etc. Irritable, 31 to 100 hertz is the gamma wave. So this is the common EEGs that can be seen. So various EEG patterns. Absence seizures, something very commonly asked. You get something called as a 3 hertz spike and wave pattern. That's something that you remember. Generalized polyspikes is juvenile myoclonic epilepsy. Hypsarrhythmias, again a very common MCQ you get in case of West syndrome. Slow spike and wave in Lennox-Gastaut syndrome. These are all syndromic epilepsies that you can get it. Focal lesions can produce focal epileptic focus. Periodic sharp wave spikes, what we call it as a PSWC, very, very characteristic of Creutzfeldt-Jakob disease that you see there. In metabolic encephalopathies, you get something called as a triphasic waves, hepatic encephalopathy, uremia, etc. And whenever there is brain death, there is something called as a electrocerebral silence. You don't get anything else. Focal temporal lobe epilepsy, you can get in focal spikes, focal slowing in a structural lesion, and diffuse slowing in a diffuse encephalopathy. So again, these are common MCQs asked, the patterns. The next topic, briefly, let's discuss on the headaches. So you have the primary headaches, migraine, tension type, cluster type, trigeminal neuralgia, etc. Secondary, where there is a cause, SAH, meningitis, brain tumor, temporal arteritis, CVT, metabolic causes, hypertensive emergencies, etc. If you look at migraine, it is unilateral usually, lasts for a longer time. Remember, 4 to 72 hours. And there is photophobia, phonophobia, and female predominance. Drug of choice for acute management is propranolol, triptans, and for prophylaxis, propranolol. You can give valproate, topiramate, or flunarizine can be used. Tension type, bilateral, tight band. Now, this can go on for days, 30 to 7 days. And there are no nausea, phonophobia, etc. NSAID is a drug of choice. Cluster headache, unilateral, excruciating stabbing pain. They can have nausea. Sometimes this can last in cluster, 15 to 180 minutes. It keeps coming the same way. Male predominance. Drug of choice is oxygen and sumatriptan, and prophylaxis is verapamil for this. Now, something that you have to remember is red flags for headache. What we have a SNOP mnemonic. So whenever the patient with headache has any of these symptoms, we should look for a secondary cause of headache. So SNOP, S stands for systemic symptoms. If a patient has fever, patient has cancer, weight loss, HIV, we will have to look for a secondary cause of headache. N is neurological deficit. If the patient has papilledema, focal deficit, it's always secondary. O is sudden onset, thunderclap, word for subarachnoid hemorrhage. Age-old, older patients, you should never rule out the headache. You have to this. Progressive pattern. If there is positional headache, papilledema, precipitated by Valsalva, this is the P's that you see. So these are the red flags. Very, very common question asked. When do you suspect a secondary headache versus primary headache? You will have to rule out. And if any of these is present, imaging is mandatory. Drug of choice for migraine, acute migraine is triptans, prophylaxis propranolol. You can use other drugs, valproate, flunarizine, topiramate, etc. Cluster headache, oxygen is a drug of choice. Prophylaxis is verapamil. Trigeminal neuralgia, drug of choice is carbamazepine, or you can do the ablation also. Headache with papilledema in an obese patient is a common scenario. Obese young patient, headache, it is idiopathic intracranial hypertension, or otherwise earlier it was called as pseudotumor cerebri. Thunderclap headache is subarachnoid hemorrhage. Jaw claudication and headache on one side, elderly people, giant cell arteritis, start steroids, very important. Raised opening pressure with normal CSF, idiopathic intracranial hypertension, and empty delta sign, which I showed you, is CVT. So these are certain questions that they can ask you. Headache with these symptoms, what's your diagnosis? Briefly, let's discuss spinal cord disease, the various syndromes of the spinal cord that can be there. So spinal cord disease is of various types. The important things that we have to remember, it's a compressive or a non-compressive myelopathy. Compressive could be tuberculosis, it could be tumor, it could be myeloma, metastasis, or trauma. Non-compressive could be inflammatory, non-inflammatory, could be demyelinating, toxin, deficiency, etc. So that is non-compressive myelopathy. The important feature that differentiates compressive versus non-compressive is pain. If there is a pain, radicular pain, vertebral pain, funicular pain, it is always compressive myelopathy. The hallmark of spinal cord disease is a definite sensory level, bowel bladder involvement, quadriplegia or paraplegia. Now, if you look at the various syndromes that you have, so the first where the entire cord gets involved, what we call it as a complete cord syndrome. That's a complete cord syndrome where the patient has at that particular level, the motor weakness, all sensations are lost, bowel bladder involvement. Classical example for that is transverse myelitis. Next, you can have something called as the Brown-Séquard syndrome, hemisection of the cord. So this is the Brown-Séquard syndrome. What happens is on the side of lesion, motor functions is lost and posterior column is lost. Opposite to the side of lesion, pain and temperature is lost. Classically get in case of a gunshot injury that you can get. Next, you can have something called as an anterior cord syndrome, where you will have pyramidal tract gone and the spinothalamic gone, whereas the posterior column is preserved. Usually occurs in an anterior spinal artery thrombosis that could be seen. Now, you could have a central cord syndrome where intramedullary lesions like syringomyelia, they start from the center and then they go out. So the patient will have classical dissociative sensory loss and descending sensory loss, florid element signs that could be there, early bowel bladder involvement, you could have it. You could have the posterior cord syndromes that could be seen where only the posterior cord is involved, which can occur with neurosyphilis. You can have involvement of the posterior cord with the pyramidal tract, classically seen in vitamin deficiency, that is vitamin B12 deficiency, subacute combined degeneration of the cord. Sometimes you can have just anterior horn cell disease like the MND. So these are the variety of spinal cord syndromes. So you should know some of the syndromes and examples. Now, hemiplegia localization, this is a very common question asked. So you can have various sites of lesions in the hemiplegia. The most common being an internal capsule lesion. You have contralateral hemiplegia, dense hemiplegia, contralateral human facial palsy, contralateral hemisensory loss that could be seen. You have a cortical lesion, you will have contralateral hemiplegia with the facial palsy, aphasia, apraxia. Now coming on to the brainstem, brainstems are crossed hemiplegias, where one side cranial nerve, opposite side weakness. So midbrain lesion, what we call it is a Weber syndrome. Midbrain is the Weber syndrome. The contralateral hemiplegia with the ipsilateral third nerve palsy, because 3-4 cranial nerves are located in the midbrain. Now, in case of Pons, the 6, 7, 8, 9 are involved there. So 5, 6, 7, 8 is usually involved there. That is there in the part there. So you will have seventh nerve involvement. On one side, contralateral hemiplegia. This syndrome is what we call it as the Millard-Gubler syndrome. Now in medulla, you have two important syndromes, lateral medullary syndrome and medial medullary syndrome. Now, lateral medullary syndrome is a sensory syndrome, so motor weakness will not be there. They will have 9th, 10th, 11th cranial nerve involvement. Horner syndrome, ataxia, and what we have cross-sensory. Same side face sensory loss, opposite side body sensory loss. This is the classical Wallenberg syndrome. Very common question asked, your posterior inferior cerebellar artery or the basilar artery involved. Medial medullary syndrome, you'll have hemiplegia with the 12th nerve involvement, with the internuclear ophthalmoplegia and medial lemniscus involvement. Spinal cord, sometimes above the level of C4, you can get a hemisection, but they will not have any cranial nerve involvement usually. So, localization of hemiplegia, the brainstem syndromes, Weber's, Millard-Gubler's, Wallenberg, you should know the features. Again, a common question asked in MCQs. Let's briefly discuss a few points about the toxicology. So we have various toxin syndromes that you could get. So we have the 5 major toxin syndromes: the anticholinergic toxin syndrome, the cholinergic transfer syndrome, the sympathomimetic, the opioid, and the sedative hypnotic toxin syndrome that you're looking at. So in an anticholinergic syndrome, the patient is delirious. Dilated pupil is what we get. Tachycardia, sometimes bradycardia. Blood pressure is usually high. The dryness of the skin that you find, secretions are dry. That is the anticholinergic. The drug of choice, we have to treat it with physostigmine. Cholinergic, the most common that you get in the OP compound. So confused, myotic pupil, bradycardia, bronchoria, secretions everywhere. Blood pressure may be high or low. A lot of sweat, a lot of diarrhea they can have, increased bowel sounds, secretions are excessive, and the treatment is atropine and pralidoxime that we have to give. Sympathomimetic drugs, though not very common, but it can be due to drug abuse, where you have a dilated pupil, cocaine, etc. if they take, tachycardia, hypertension, and you have to supportively treat this patient. Opioid, this is very, very characteristic, very important. Bradycardia, bradypnea, pinpoint pupil, and this is where you have to give naloxone as a drug of choice. Sedative hypnotics, very common with barbiturates you can get. Here the antidote is flumazenil. So they can give you a clinical scenario and they can ask you the management, what toxin syndrome this behaves as. The other thing that you have to remember is your snake bites. So 3 types of snake bites that you get: the myotoxic, the hemotoxic, and neurotoxic. Neurotoxic usually have ophthalmoplegia. They can have respiratory muscle paralysis and motor weakness. The hemotoxic usually has bleeding and renal failure. And the cytotoxic has local myotoxic effects. So various snakes produce similar features. So whenever you have a snake bite, look for the symptoms, whether the local swelling is there or not. If you have a lot of local necrosis, could be myotoxic part of it. The patients can have those. So compartment syndrome requires antivenom therapy. Neuroparalytic, cobra and crate, very important. Ptosis, diplopia, dysarthria, dysphagia, and paralysis. These patients will require ventilation. You also have to give them atropine and neostigmine. That's very important. The vascular toxic, viper, that is there, so usually present with bleeding. You do the whole 20-plate whole blood timing, that will not clot. Renal failure may be there. Again, ASV is the drug of choice. Fresh frozen plasma you may have to give. Dialysis may be needed. Myotoxic, that's the sea snakes you get, where you have a lot of rhabdomyolysis and the patients can have renal failure. ASV with dialysis is the treatment. So always look for what is the symptom, and based on that, you have to go and manage these cases with snake. So again, they will give you a clinical scenario and certain lab investigations. The whole blood clotting time is prolonged. Then we know it is possibly a viper. You will have to give the ASV. You will have to give FFPs maybe. Watch for renal failure and maybe dialysis is indicated. For neurotoxic, that's the cobra. Atropine, neostigmine, 1 set of ASV is given, and then ventilation early and supportive care is what is needed. Students, in today's session, we discussed certain common high-yield areas in neurology and toxicologies. I showed you a lot of image-based as well as the video-based sessions that we have. And based on that, we have understood how do you approach the common scenarios. Please remember, stroke is an important thing that is going to be asked. The neuropathy is very important. That's asked. GB syndrome, very important. Acute ascending paraparesis or quadriparesis, generalized areflexia, and you get the albuminocytological dissociation. You will have to start the patient on plasmapheresis or IV immunoglobulin. Myasthenic crisis, the patient can come with fatigable weakness, reflexes are preserved, the patient can have respiratory paralysis. Again, these patients will require plasmapheresis, and they will have to be given pralidoxime, and then you will have to give them pyridostigmine and steroids as a mainstay therapy. So neurological case scenarios and the images, various movement disorders we discussed, and how do you identify the gait abnormalities we have discussed. So is there any questions that are there in the video chat that's going on in YouTube? Let's see if there are any questions. I will answer it. I'm not seeing any questions in the live chat that's happening there. So I think you can go through these in the later time when you can see these. Look at these tables, and I think the annotated class notes will be circulated. So you can read about it and understand it better. We will see you tomorrow with one more session of medicine high yield questions and approach. We will be discussing about endocrinology and rheumatology in tomorrow's session, and we'll try to get some high yield questions and points in tomorrow's session. Hope today's session was useful. Thanks for joining, and see you tomorrow. All the best. Thank you.